Several articles mention possible higher risk among people who take ACE inhibitors or ARBs for hypertension. Is there actually a higher risk? Has this been tested? Let's start with a brief overview of the ACE receptor with respect to SARS-CoV-2. The SARS-CoV-2 virus attaches to the ACE2 receptor in order to infect a cell. Cells that lack ACE2 do not get infected with the virus. ACE2, also known as Angiotensin-Converting Enzyme 2, is an enzyme found throughout the body to counteract the action of ACE1 in the renin-angiotensin system. Together, ACE1 and ACE2 function to regulate blood pressure and salt balance. ACE1, ACE2 imbalances such as higher ACE1 or lower ACE2 are seen in many disease processes such as atherosclerosis, high blood pressure, heart failure, chronic kidney disease, inflammation, and lung injury. When SARS-CoV-2 virus enters human cells via the ACE2 receptor, the ACE2 receptor is internalized into the cell with the virus. This results in a decrease of the number of functioning ACE2 receptors and worse disease severity. This has been shown to occur with the original SARS-CoV-1 virus. The decrease in ACE2 coupled with the cytokine storm creates a vicious inflammatory milieu, which can spiral out of control and lead to acute respiratory distress syndrome. This is supported by data from animal studies where acute lung injury decreases ACE2 receptor levels, and this exacerbates disease severity. But vitamin D increases ACE2 levels, and this was shown to protect against acute lung injury. In short, ACE2 is a key protective factor for severity of lung edema and acute lung failure. The epidemiology of COVID-19 also supports this. Those with decreased ACE2 levels are also those who have been seen to have more severe COVID-19 cases. This includes people with chronic diseases, elderly, and males. It has been hypothesized that since ACE inhibitors and ARBs, which are angiotensin II receptor blockers, increase ACE2, they may reduce the risk of severe disease in these populations that are at risk. Several cardiovascular societies have recommended continuing taking ACEs and ARBs. They argue that the increased protection from severe disease the ACEs and ARBs could provide is worth the theoretical trade-off of increased risk of infection. In fact, there is a paper suggesting that ARBs should be used to treat COVID-19. A case population study from Madrid involving 1,139 cases and 11,390 control subjects assessed whether antihypertensive drugs affect the risk of contracting COVID-19 requiring hospitalization. Compared to the other hypertensive drugs, RAS inhibitors such as angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, which increase ACE2 receptor levels, were not associated with an increased risk of COVID-19 requiring admission to the hospital. In fact, patients with diabetes taking these inhibitors had a decreased risk of COVID-19 requiring admission to the hospital, suggesting a possible decrease in disease severity. But more data is needed and only time will tell.